Hi everyone, today I'm here with Dr. Teda, who is a pediatrician in the Sacramento area who also does work with community advocacy and other things like that. So first of all, Dr. Teda, thank you for being with us today and for agreeing to this interview. Just before we really dive deep into kind of your background and what you think of the specialty, could you just give us a brief overview of what pediatrics is and also what it generally involves?
Pediatrics is the treatment of children from birth through 21 years of age. So oftentimes pediatricians are available at deliveries. If it's a high-risk delivery, they can be called to come to the delivery in case there's an issue with the child. Also, for healthy newborns, we're there after the birth to do an assessment of the baby and check on them before they go home.
And so now going into your background, why did you choose medicine and pediatrics in particular?
So I always sort of liked how things work. And I realized that, the human body is pretty amazing, that from cells and from organ systems, and I thought that'd be really cool to learn more about that. And I also sort of had this love for mysteries and figuring out things. So for me in medicine, it was how did this happen that caused this to happen? In high school, I was an athletic trainer with other students, and that was being on the sidelines on the field. And you'd see someone go down, and you'd be like, they're in pain. Well, what caused it? Well, when they fell, they twisted their knee this way, it must be this. And sort of learning about how they got hurt, how to help them rehab. And that sort of sparked my interest. But I had other skills that I realized, I think all the skills I feel like I have and with my interests would go into medicine. I also specifically chose pediatrics because I think I had an interest in peds in the beginning, but I realized I didn't like going to the clinic, and if I had an adult and they'd bring a whole Ziploc bag of medicines, and I had to sit here and go through all of them, and I thought, if we helped address this issue before it gets to this point, maybe we wouldn't need this whole bag of medicines. So I appreciated that in pediatrics, we were able to intervene early and sort of help make positive choices in children's lives, and then there's an effect in the future. Also, if children are really ill or sick, or when they're in the hospital for things, kids can bounce back quicker because when you're younger, you're able to heal a little better compared to adults.
What type of specialties are there in pediatrics?
Pediatrics, there's specialties that pretty much range with the same ones you'd see in adults. There's cardiology, nephrology, neurology. Geneticists will do pediatric genetics, but they also do adults, so they just usually get trained in genetics on its own. There's also orthopedics specifically for children, same with surgery specifically for children. And I will say the fields of infectious disease, they usually cover both children and adults. And there's also neonatal intensive care unit, or NICU, and pediatric intensive care unit, or PICU. And there's also child development, or developmental behaviorist, which focus more on behavior, ADHD, and there's also pediatric neurology, just off the top of my head.
Mm-hmm. And so if you're doing something like pediatric surgery, would you have to do that 3 to 7 years after pediatrics?
Excellent question. For pediatric surgery, you would still start with general surgery, but then you do a fellowship in pediatric surgery. Mm-hmm. So after doing whatever training program for general surgery, you would work for pediatric surgery. Okay,
so then you apply gen surg and then would it be a fellowship then in pediatrics?
It would be a fellowship in pediatric surgery.
Okay.
So I will say when I was in residency, we'd have the pediatric surgeon come, and there were people that rotated with the pediatric surgeon, but they were residents that wanted to do it just to see what it was like. Mm-hmm. But pediatric surgery would be one of the services where you don't have to, you don't have to, where you don't do a pediatrics residency. Mm-hmm. For example, pediatric neurology is usually you can do 3 years of pediatrics, and then you can go on and do 2 years of neurology, but some programs have you do 2 years of pediatrics and then go straight into neurology. Some people, after doing their first 2 years of pediatrics, decide, let's just do the third year of pediatrics, have the complete training, and then go into neurology. Mm-hmm. And I believe I almost forgot, pediatric endocrinology is also especially for pediatrics.
Mm-hmm. So what type of cases do you usually see in a day?
In a regular day, I would say the majority are child checks, or that's your annual physical. For children, there are more visits when you're under the age of 2. Usually When you're born, there's the first visit within the first 2 or 3 days of life. Then there's another visit at 1 month. Then there's 2 months, 4 months, 6 months, 9 months, 12 months, 15 months, 18 months, 24 months, which is the same as 2 years of age. There's a 30 month that's been worked in recently, then 3 years old, 4 years old, 5, and then after that, once a year. So adults will usually have an annual physical, but for children under 2 years of age, there are more visits in between. Oh, sorry. So that's usually well-child checks. Other than that is going to be the acute visit for fever, for other concerns that might pop up, or sometimes a parent might come in and say, my child's not talking as much. Usually we try to pick that up on a well-child check, but sometimes if a child's not been seen in a few years, or if a family lost their insurance and then they come in, then you're sort of trying to pick up where someone else might have left off. So it's a range of regular visits where you're just checking the overall health of a child, to acute illness visits, and with pediatrics it tends to be sort of seasonal. So if it gets to be fall, winter time, you see more colds. When it's springtime and summer, we see more seasonal allergies, but also 4-year-olds and 5-year-olds getting ready for school. And then in the fall, we have teenagers coming in for sports physicals, or they're getting their Tdap vaccines, or they're getting ready for college and they're getting vaccines for college. So in pediatrics, it tends to be somewhat seasonal, but one of the consistent things are well-child checks.
What's kind of the difference between like a family medicine, like scope of practice, versus like a pediatric scope of practice with kids?
Excellent question. I would say that in pediatrics, I learned all about newborns through age 21. Family practice is looking at newborns through geriatrics. And I will say, in my medical school, we had a family practice clinic that we did work with, and that was my continuity clinic every week. And we would work with a woman that from when she found out she was pregnant to all of her prenatal visits, and then when she needed to deliver her baby, we were there to deliver her baby, then we took care of the baby and her. And I thought that was cool to go, oh wow, I'm seeing this all from start to finish. But in the future I said, how am I going to manage knowing all this information? I'm like, I can't be the MacGyver of medicine, and I guess to be more updated, I can't be the Jack Bauer of medicine. So for me, I said, what if I focus on children? And for family medicine, many people that I know personally that do family medicine, they don't stay on top of the whole gamut of the information with family medicine. Many people I know said, well, I'm going to focus on OB-GYN and psych, or I'm going to focus on adult medicine. But with family medicine, you have that sort of general scope on the whole life cycle. But I will say for some things, you might say, I'm not sure about this, because you have some information about a lot of things. In pediatrics, you have a lot of information on everything.
What's a typical day in your life like, or a week if there's a lot of variability between days? Okay.
And you mean like right now, what is it like, or in general?
In general, for most pediatricians, maybe like, now I'm guessing you do more academic, but I guess before that.
Right, so usually, well, you go to the office. I would say pediatric practice is not one of those things you can just do from home. And in the office, there's a balance of seeing patients in the office, but then also you may have parents calling in and saying, my son has a runny nose, or they have a cough. So you're also sort of triaging, okay, does this person need to come in, or do they need to go to the emergency department? So you might be saying, oh, please call his father back and say they can make an appointment for tomorrow. Or if someone calls and says, my child has a broken arm, okay, they need to go to the emergency room. Also, you're also addressing issues where it comes to prescriptions. Depending on the practice you have, depending on insurance plans, is a whole scope of, is this medication on that patient's health plan formulary? So you may also be fielding phone calls about, oh, this was not covered, can you change this? Or the pharmacy is out of this, can we substitute this? So you're also keeping in touch with pharmacies about making sure prescriptions are filled. Also, you're looking at lab results. If you've seen a patient in the office and you order labs, you need to check them to see what's going on with them. So if I'm checking lab results, I'm marking off that they're okay, or if we need to contact the parents and let them know about the results, we'll do that. Amidst doing all those things, you're still seeing patients. So in the office, I'm seeing patients, or if I see someone, they're not breathing well, and I examine them, we need to do a breathing treatment. So I'll have one of the medical assistants come and get a breathing treatment started. So you're sort of balancing many different tasks in the same day, which keeps it sort of versatile. That it's not just everyone is the same coming in, because I may see a 15-year-old and do a well child check with them and realize, oh, everything's fine with them. But then after that room, I go to a room with a newborn that's 2 days old, and the parents are brand new parents, and they have a lot of questions about taking care of a newborn. To a 4-year-old that I'm doing their physical, but the parents tell me, well, they can't talk. They only say 1 or 2 words. And then I'm talking with them about developmental issues. So there's a big range, because with pediatrics, you're going from birth to 21 or in college. Mm-hmm. And even at that age, we're talking about, well, here's how you need to transition to an adult medicine physician. So what you do in a regular day can vary, and I wouldn't say it's predictable, because you just never know. And I will say, even earlier this week, I was in the office, I was seeing a patient, I was pulled out of the room because they said a parent just ran in and said their child is unresponsive, and they drove here and the child's in the car. Mm-hmm. So I literally dropped what I was doing, ran out to the parking lot, and I did the sternal rub and yelled their name, and they were just like, they groaned. And I said, yeah, we need to call an ambulance. Mm-hmm. So I did not plan for that to happen, but in the moment, we were mini emergency room triage, because I don't know if this person had been on drugs or any of that. I just knew they were not responding, and that was telling me this is an emergency. They need to go to the emergency room, because we did not have the proper equipment or medicine to be able to help them in the office.
Mm-hmm. And what are the hours usually like? Is it like a typical business kind of day, or is it longer?
Mm-hmm. I will say most offices will start as early as 8 or 9, mm-hmm. and some offices will close at 5, or sometimes they might be open a little later, till maybe 6 o'clock or so, to help accommodate families with work schedule. Because with pediatrics, the child did not get there on their own. Mm-hmm. Someone brought them. Mm-hmm. Parent, aunt, uncle, grandparent. And I will say that with pediatrics in all different areas of medicine, it's all about documenting the visit, but also there are things regarding billing, that you're filling out papers, or if you need to write a referral for things, doing those things. So most people will end their day after they finish their charting and everything, and that can be sometime like 7 in the evening or so, depending on the hours of the office. But there's always, at the end of the day, checking lab results. Is anything an emergent issue that you need to contact the patient or the family directly.
Mm-hmm. So it usually lasts a couple of hours to like 7 or 8?
Yeah, but I will say, I'll be honest, there's some days where it's not 7 or 8, but also it depends on the acuity of that day. Mm-hmm. That there'll be some days where I'm done pretty quickly because everyone I saw that day was healthy, no major issues. There might be another day where every other person I saw needed a referral, but they had something very complex. So I need to make sure when I write my note that day, I'm describing everything to the health plan in so many words with my note, so that they understand this is why this child needs this referral, mm-hmm. to make sure it goes through.
Okay, and how is the lifestyle in pediatrics different from other specialties?
I will say in pediatrics, you're going to get sick. Kids carry germs, and I will say that even when I was a student, almost everyone that did pediatrics with me got sick and had to take a day off. But I was like, I'm not getting sick. I took my vitamins, I washed my hands, and I was on the rotation in the middle of November, and I was like, I'm not getting sick from these kids. I will say I don't know many other areas of medicine where people are so quickly prone to get sick. I will say by the time you're practicing, you've been exposed to so much that by then you're like almost invincible. Like we've joked that we could take some serum from ourselves and it'd be like so strong. But I will say that I would say it's pretty similar to most outpatient medicine work. That if I was working inpatient pediatrics, that'd be different because that's a hospice schedule. Mm-hmm. In a hospice situation, you may be on for a week, but you're only in the days. So you're doing all of the care for children on the hospital floor all through the day, and then you give sign out to the person that comes on at night, and you're on for a week and a half, and then you're off. And then you're back on. And then if you work nights, you'll be on the nights for a week. So that schedule's different. But with outpatient pediatrics, it's mainly the day-to-day, Monday through Friday. You may share call over the weekends or over the weekdays with other physicians where people might call with concerns. Also, there may be rounding in the nursery that happens, where you go to the nursery, you evaluate babies, before they leave the hospital, and then they come and see you as an outpatient.
Before we were talking about how like you did an MPH and you do community advocacy work. How do you recommend physicians, even residents maybe, I guess residents are probably busy, but how do you recommend physicians pursue other areas besides just their clinical practice?
So I was interested in earning my Master's of Public Health as a student, and my medical school did offer an MPH program, but I got to the point where I said, look, I just need to finish the medical school part. Let's not add on anything extra. And I was interested in it because Master's of Public Health, or public health in general, is looking at how can we address health as population-based. In medical practice, it's you and the patient in the room and what you can do on this level. But population-based medicine is, well, what can we do for a large group? Hence, that's things such as, for example, physical education requirements within the school district. Making sure there's a certain amount of physical activity or a number of times PE should happen during the week. And it's looking at things on the larger level. I did a fellowship following residency completion where I was doing both the Master's of Public Health, but also doing general academic instruction. So they were helping me learn better how to teach both residents and students, but I also did the Master's of Public Health, and my focus was on community advocacy, looking at different resources in the community that children are exposed to, or just looking at that as a resource, mainly because I knew very clearly in my interaction in the office, I can only do so much there. But it became a bigger deal when I was talking to children, for example, and they were obese, but the parents would say, well, the food at the school is junk food. So on the population level, the question is, well, what could I do to see if we can not have as much junk food at the school? Or when a parent says there are smokers in our apartment building and the child has asthma, well, that's something about the child's environment. What can we do to say, okay, can we have rules against having apartments where there's smoking, or do they need to move somewhere? And looking at other factors, or we call social determinants of health, that affect children. I know the American Academy of Pediatrics, or the AAP, has recently had a large charge looking at poverty and how that affects child health. And that's also on the public health level of how one factor can have different ramifications in a child's life. To get interested or get involved in those things, part of it is being curious. I will say as a resident, I came up with different projects or different things that I did out of necessity. We had patients on the floor that needed to see a psychiatrist, but we didn't really need a psych evaluation, but we wanted them to get linked with someone. I called our psych department. We were able to find a way to streamline our referrals for patients that didn't need one at the moment, but they needed to see someone in the future. Children that have a special fracture of their femur need to go and get a special cast called a SpicaCast, but they couldn't fit in a car seat. When I was in residency, I put together a SpicaCast loan program with 2 car seats that had been donated because a family had been driving with their child in the car. The police said the child was not properly restrained in the vehicle, and they got a moving violation ticket for hundreds of dollars, and they couldn't pay it. And so this way, it was to help parents be able to transport the child in their car without having a risk of getting a ticket, which was, again, related to medicine, but not necessarily the health care given in the office, but another sort of offset of that to benefit the child's health because they need the cast, but also keep the parents from being concerned about being able to transport them around town.
So do you have protected time for this, or is it like stuff you do like on the weekend? Or
in residency, I look back and I have no idea where I got the energy from because those were things that, I kid you not, with the SpicaCast, we had a child that was being discharged home. It was Friday. The county hospital's ambulance did not run on the weekends, and we were potentially going to have him in the hospital until Monday just because we couldn't transport him home in an ambulance. And then I said, wait a minute, we have those car seats. And someone's like, well, where are they? So I went looking for them. Within a day or two's time, I whipped together a loan form, and I spoke with the orthopedics department and said, look, how about I made this form, you cannot take this cast off unless they bring this car seat back. So the program was born out of necessity, just because these were costs that the health plan was not going to cover. but the child couldn't go home in a regular car because it didn't have a car seat to fit them, and the ambulance wasn't functioning and wasn't in order over the weekends, and the ambulance ride home alone would have been $500. The car seat itself cost $500, but we had 2 of them, and being able to use a car seat more than once would have clearly saved a lot more money than waiting till Monday and having 3 days of hospitalization costs plus paying for an ambulance to go take this child home. So after doing that one day, we made it the new program, and then I presented my findings of this program at the AAP conference that year, which was in San Francisco.
Okay. So what's one misconception or a couple misconceptions, if there are more, about pediatrics?
I think the biggest one is that A, is really easy, and B, that all we do is play with babies all day. Children come in all shapes and sizes, and I think people think, oh, it's just kids. It's not that hard. It's not a big deal. But I would say children don't really tell you exactly what's going on, especially infants. You just have an infant, and you're supposed to figure out, well, what's happening here. So you have to sort of think more about what the parents are telling you or asking the right questions. Also, you need to really be astute with your physical exam skills, because the 4-month-old is not going to tell you, yeah, my stomach really hurts, and that's the problem. Teenagers can be very complex. That when I was in the emergency department as a resident, the chief complaint said abdominal pain, and people did not want to go there because they knew if they're coming here with abdominal pain, how do we know it's really abdominal pain? Or if it's a female, are they pregnant? Are they depressed? Are they suicidal? Because teenagers have so many different things going on. You have to sort of address it differently and sort of get down to what the real issue is compared to what they've said they're coming in with. I would say that sometimes with children, it's hard to do an exam because if a child does not want you to look in their ear, they will not let you look in their ear. And you have to find ways to either be supportive of the child and the parent so that they will let you look in their ear, but also how do you make sure you get it done? Sometimes there'll be more than one child in the room. They come with their siblings. You might have to be a referee sometimes and be like, stop hitting JoJo, be nice to Susan, I need to examine Tiffany that's here. So I will say that there are things that are different that you really have to have patience. I tell people all the time, if you're not patient, don't do pediatrics. If you're a germaphobe, don't do pediatrics because stuff might get on you. I've had babies pee on me sometimes. It happens. I just wear machine washable clothes. But I would say that when people think that it's just easy because it's children and it's not that hard, completely, that's a misnomer. It is challenging.
Since you mentioned the germaphobe and the being patient, I was going to ask in the like later on if there are certain personality types that are better for pediatrics. Besides that, are there anything else that makes you good fit?
I think you have to sort of have a good sense of humor with yourself and even with children. That I think the other day I asked a child, so what do you want to do in the future? And they said, be a police officer. And the parents said, well, ask her why. And I said, well, why? They're like, I like donuts. And I just had to be like, okay, you like donuts. Got it. But I mean, this is also a 6-year-old's logic, that those are the moments you can enjoy of, you forget what it was like to be 6, and that you're focused on future careers because you get donuts. As you mentioned, next to patience would also be always being curious. If someone just says, yeah, I have mood swings, okay, well, what type of mood swings? What does that mean to you? How often do they happen? Asking more questions, because teenagers and kids are not going to always tell you everything. A child came in one day and their ear was hurting, and I looked and I saw that their eardrum was ruptured, and I asked, has anything hit your head recently? And they said, oh yeah, someone kicked a soccer ball and hit me in the side of the head. And the mom went, you never told me this. And the kid said, you didn't ask me. And so you may not always get to the bottom of the story just by asking questions or expecting them to tell you everything. You just always have to be inquisitive. I think that's in all medicine, but I think with children, you're not always going to get all the information just given to you. You sort of have to pick more. I think also you have to be a little bit of a psychologist, because I will say this, one of the biggest challenges sometimes with pediatrics is the parents. And sometimes you need to sort of understand, well, where are they coming from with these questions? Or what is on their mind? I had 2 parents tell me that their 12-month-old had ADHD because their 12-month-old was so active. And I looked at the infant and it was playing with the paper on the table, and I had to explain to them, well, actually, 12-month-olds, this is normal. And this is okay that they're active because we'd expect them to be active. But it's sort of a blend of all those things because you're sort of working for multiple different audiences in each visit. And sometimes if it's a 10-year-old and the parent, okay, you're working with both of them. If it's a 2-month-old and the parent, okay, it's a 2-month-old and the parent. When they're 18 years old, it's just an 18-year-old. So you have to have that flexibility also of understanding when you come in the room, you have to sort of change your schema of what you're doing depending on the age of the child.
What are the most challenging and rewarding aspects of pediatrics?
Rewarding would be when I've seen a child over a period of time and seeing, let's say, a challenge they had previously. Let's say, I can say of one child right now, I met them when they were 6 months old and their mother had been on drugs and they were adopted by another family. To then see this child later on at 4 years of age, doing well in school, excelling, not having any other health issues because they were in a good setting. It's just great to see, look, you had a rough beginning, but look where you are now. I think also when children have had, I will say rewarding in one day I saw a child and the parents said, you know, they've been losing a lot of weight and they're always thirsty. Something's not right here. And I looked at them, I looked at the growth chart, and the child's weight had been dropping over the past 4 months. And I said, you know, let's check your urine. And the urine had like 4++ sugar. And I said, okay, I think your child may have diabetes. You're going to go to the emergency room. Just take your time getting there. And the child did. And the child got treated, got started on insulin, and the parents, after that, they just thought I was the greatest thing since sliced bread. They're just like, oh, thank you, thank you, thank you. And I'm like, I just did what I was supposed to do. You came and you told me these things were going on. All I did was address it. I think being able to find something and say, here's this, and being able to help a family. I think you asked also what was most rewarding and then what the challenge is.
What's most challenging about pediatrics?
I will say, as I mentioned before, it's the parents sometimes. I mean, not all parents are bad. I will say that it's hard when, for example, there was a child I saw that was morbidly obese, was in special education, but was flunking. And we had done a Vanderbilt assessment, and I noted, well, there's ADHD and these other things going on. And I explained, well, this is what your child needs to do better in school. They need this medicine to address the ADHD. And the parent was like, sure, okay, we'll do it. But then later on, never gave the medicine to their child. And they were still flunking school. And I tried to explain again, because this child might have been somewhere between 11 and 15. And they're like, well, I don't want to do medicine. And I explained, but your child's flunking special education. That's telling me that this is not working. We need to do something to help things. And to have the parent just really not being receptive, but my concern is, where is this child going to go in the future? If they're not getting the help they need, and in the future, they're just going to be living at home forever. I want to help them be a good, what is the word? Can't think of the word right now, but help them give back to society, be a good citizen. And at this rate, if you're already flunking in special ed, I don't know what's going to happen at this point in time. And if the family or the parents don't feel as motivated to be concerned about what is this issue now, when they're younger, when they get to be 18 or so and they have not finished school, it's going to be more of an issue then.
Do you have to deal with anti-vaxxers a lot?
Yeah, that comes up.
How do you deal with it?
I will say that it differs. I've had a parent that when I just asked casually, oh, so I see your child hasn't received vaccines, they just went off on me. But they said, well, everyone I talk to, they give me a hard time. And I said, I just want to know, because it was a sick visit, and I happened just to notice it. I know other times I've had parents coming in to get their children vaccinated because they're going to school. And like, okay, I'm doing it because they need to go to school. I've had a parent that had a child that had heart surgery and heart complications, and they were telling me, I'm a registered nurse, and vaccines are dangerous for my child. My child has this heart issue, and they shouldn't get vaccines. And I remember saying to them, actually, because your child had this heart condition and they had the surgery, this is more reason why they need the vaccines. So I've seen parents of newborns that maybe 2 weeks ago a parent brought the book written by the pediatrician that is all about not vaccinating, saying, we read this book and we really think we want to follow it, and what are your thoughts? And I sort of took a deep breath and I was like, well, here's what I see, because we rather encourage parents to vaccinate, and not just because we said so, but I try to give them a brief overview of, well, here's why we vaccinate, to protect from these illnesses. I say, well, we don't see those illnesses anymore. I'm like, exactly, because we vaccinated. And I know that I'm not going to change a parent's mind when they come. I will say, when I see parents that haven't vaccinated their children, and I will say, it's a small number, but every now and then I'll see newborns and the parents are like, yeah, we're not doing that. I at least make sure I present with them the information, ask them if they have any questions, because there's still a chance to get caught up later. It's just taking a little trial and error of figuring out what's going to be the best way to approach this, because I don't know what their previous experience has been. Are they going to bite my head off and yell at me about stuff? Some parents will say, well, I want to follow this other schedule. Can we just give 2 at a time? And I'm like, okay, we can do 2 at a time. I'll work with you if you want to vaccinate your child. If you don't want to do all these this way, let's just at least get them vaccinated. But I also let them know, you're going to see the beautiful people on TV telling you certain things. I'm not one of those people, but I spent a good chunk of my life studying these things to help protect your child, and this is what I'm saying, but they're not going to put me on TV. So it is that balance between knowing, well, this is why we do things, but also some people have a louder megaphone to get the information out compared to others.
So how would you recommend getting into or matching into a pediatric residency, and maybe what you'd recommend a med student do throughout the course of their study to increase the odds of that?
Well, I tell everyone, no matter what rotation you're on, if you're on surgery, if you're on emergency medicine, if you're on internal medicine, learn as much as you can on that rotation, because that's going to be the one time you're going to have that exposure, that experience. Because I tell people all the time, don't just say, well, I want to do this type of medicine because I saw it on TV, because that is always television. But once you sort of know, I think I want to focus on this, the key part is doing well in those rotations, because there are skills you can take from every rotation you've done that will help you in the area that you want to concentrate in the future. For pediatrics specifically, usually people say, well, do well in your pediatrics rotation. But I will also say, even if you don't do well on your pediatrics rotation, but you know that's what you want to do, that shouldn't hinder your desire to do it. If anything, when people are interviewing for residencies, the first thing they're looking at is this person going to be a good fit for our team? They already know who they have there, and they want to know, is this person going to work hard? Are they going to work well with the other residents? Are they going to work well with the other nurses or respiratory therapists or other ancillary staff? Because no one wants to have someone come on their staff that's going to cause trouble, because no one needs drama. Especially if you're working with patients that need help, you don't want to have someone saying, well, I'm not working with so-and-so because they did this team and they took my room and this, and this. No one wants that. That with any residency program, they want to know that you have a passion for that field. For medical students, I would recommend either joining the student branch of the American Academy of Pediatrics. The membership is free, and for students, you can also attend the national conference and exhibition for free, as long as you show proof of being a student. And they rotate the location for that every year between the West Coast, East Coast, and Midwest. Also, being exposed to children, being involved in other groups that have things with children, be it, do you see if the local crisis nursery, if they need people there, or as a student, I mean, time is not your friend, but if there are even events where you can be involved. I know a friend of mine works for the school district. She's asked me to come to the school and do the puberty talk with the school. So that was a way for me to come and share my knowledge with students that are, in grade school. But just having an interest in things related to pediatrics, I think would be key.
You mentioned that the hours can range from 8 to 7 or 8 to 8 or so, and I've heard that pediatricians aren't compensated relatively well compared to how much like work they put in. Would you say that this is true? And if it is, how would you recommend maybe increasing your compensation in whatever practice setting you're in? Not that financial like considerations are the most important thing, but obviously with a lot of debt and a lot of time that you're putting in, you want to try to maximize that a little bit.
I will say you're right when it comes to compensation is not always equal. For example, when parents call the office, that's a lot of time and energy to respond to each of those phone calls, but most health plans say, well, that's part of the management of the patient, and we're not counting that. But when you look, there can be some patients that they call twice a week, or they call at least once a month, and some that don't ever call until they need to make an appointment. So that's something that across the board most health plans don't cover. It also depends on the type of patients you're seeing. If you're seeing a private pay patient compared to a Medi-Cal patient, so that many offices, if a large number of their patients are Medi-Cal, you have to see a certain number to make sure you're reaching a certain price point. For private pay, it's a whole other can of worms. I know that there are other opportunities when people either do like urgent cares. If there are ones specifically for pediatrics, they need people to help cover when they're in business either during the week or on weekends. So I know I've worked in urgent care here and there. Other people will sort of cross-cover at other places. There are also things such as locum assignments, which locum tenens is when people fill in when an office either is short-staffed or let's say someone goes on maternity leave. So some people might cover there. I do know some pediatricians that's all the type of work they do. They just work locums. They don't have health benefits with that position, but they just work at different places so that they have enough hours during the week because they haven't found the right sort of niche for them. I will say, though, that in medicine, even if pediatrics compared to other areas of medicine and specialties is not as much as others, you're still earning more than the average Joe Schmo on the street. But you're right. Oh my gosh, I have all these loans. There are different loan repayment programs through both federal and the state that will pay back portions of your student loans for the amount of time that you serve in underserved areas. I know one, the Stephen L. Thompson Award, is for anyone that's doing primary care, that pretty much they'll pay back $30,000 of your loans each year for 3 years. So for a total of about $90,000 by working in an office that's either on their list of offices for need, or if the office sees at least 50% of the patients are from under Medi-Cal. The federal government has the National Health Corps program where, again, you work at one of the offices they've listed according to need, and they'll pay back about $100,000 if you are in a area that's underserved. Also, I know I trained at a county hospital for residency, and if you train or work in certain fields for a certain number of years, there's a point where if you have so many years of service, there's total loan forgiveness. So there are ways to at least help bring that number down a little, that you can at least be done and not have as much of a concern for it. I know some people that, I don't know what magic they did, but after residency, a year or two out, they'd already paid back their loans. And I'm like, did you sell a kidney or something? Like, what did you do? But I will say that I've always joked, if I could win the lottery, the first thing I'd do would be pay off my loans, pay off my loans, and then be able just to move on from there. That it is a factor that everyone has in their mind, but there are different programs to help cut down those costs in the end. But I will say, as you mentioned, well, what other things can you do? The hard part is if you're already working full-time at one place, to have the energy to do other things. But I would say that usually coming into it, finding programs that you'll be able to take off some of the costs for your loans helps out. But also people, like I used to cover in the urgent care clinic once a week. Once a week, 4 times a month, it was a small little extra thing on the side.
Are there like scholarships and things available also for people that take private loans, or is it only for public?
Oh, it is just loans. If you're doing for medical education, loans. They're not asking, are you doing private medical school, public medical school? They're just saying loans. I will say, I think when I graduated, I had probably about $300,000, and actually I maxed out all federal loans and had to go private for whatever amount it was. I can't remember now. But when I finished medical school, that's the first one I paid off, and then the rest were remaining. I do recall because I went to school in Illinois, there was a program there that the state senator could give a scholarship to people if they were going to a state school, and there are different things through the legislature, but oftentimes I found out things because I spoke with other people. And there will be other things where there's like, oh, are you wanting to go into OB? There might be through the National OB-GYN organization, oh, we have this scholarship, or through this, there's this scholarship. And I'll be honest, I don't think there's one for peds, or I haven't found it yet. But I will say there are different programs that will say, oh, we want to support future pediatricians or future surgeons, and they will help out with fees, or they'll say we'll help out with $5,000, which you might say that's only $5,000, but when it comes down to it, it's $5,000 more that you didn't have before.
Okay, so you mentioned like picking up an extra shift day. I'd imagine that gets pretty like hectic with your on top of your work schedule as well. So what are tips that you recommend for people to avoid burnout and establish a work-life balance?
Excellent question. I would say even how to keep from having burnout as a student in residency, still remembering the things that you like to do and making time for them. I had a colleague that when she was post-call in residency would go surfing. I mean, we were in LA though, but she would go surfing, then go home. I like doing photography. I would still say, well, I'm going to go do this today. I think also, even now, as a pediatrician, I try to do my work and leave it at work. So when I go home, I'm done. I used to do some charting from home, but then I realized then I can't leave my work at work. Then it's following me home, and I have that going on too. Sort of making boundaries for yourself of, well, how much contact are you going to allow beyond here? You know, are you going to have patients send you messages through your Facebook account? Are they going to be looking at your Instagram going, hey, I see you? Are you the... No. You want to make sure you have sort of protection for your personal time. If you have family, making sure you have time to spend with your family. I will say in residency and medical school, your time is not your own, because you're told, you go here, be here from this time to this time. And that is hard because you're just so used to people telling you what to do. But after that, you have to say, okay, I need to make the time for this. In medical school, we had an intramural volleyball team. That the team wasn't really set. We just said whoever can show up, show up. And it was Sunday nights were the games. And people from the community were on teams said, well, how do you guys make time for this? And we said, you know, you make time for what's important. And we just knew if we study ahead of time, we could go. And then we'd leave and go back to studying. So we were able to do things in the guise of, let's set up the time to do it, and we'll do it. Then after that, we'll do our other work.
Talked about finances a little bit. What tips would you give us, give physician, like newly minted physicians once they graduate from residency, or like even later on to kind of optimize their financial situation?
Okay, got you. Well, I know in medical school, I was like, when I get out of medical school, I'm going to get cable in my house with internet, because I didn't have that in medical school. I was able to work without it. So I think we all had very basic goals of what we're going to do with all this money we were going to get from residency, which is not a lot, but at the same time, when you've been paying for a while and then you're getting a paycheck, it was like, what? I am rich. I would say keep the same car you have. I drove my car through medical school, residency, until maybe 2 years ago. I got a car because it was getting to the point where I said, you know, I worked really hard. I think my trunk should open, because it didn't open. I would say, as you mentioned, sort of looking at your finances. If you need to, just check with a financial advisor. Not that you're going to say, oh, I'm going to start investing this, and this, but they can help you just sort of figure out, okay, what do I need to do with my loans, with what I'm doing with where I'm living. If people say, well, I'm going to buy a house, this and this, they'll help you sort of figure out those things. I finally made an appointment with one maybe a year ago. And also, if you check with people, I mean, I personally know someone now, but I let people know, hey, you want to speak to my person, just to meet with them, to help you just sort of lay things out. Because they help me figure out, okay, here's how you're going to pay down your loans. You pay this, then do this with this, as you do your car payment and everything. That will just help you sort of get an idea of what am I doing with my finances. I think the biggest thing is spend within your means. Even though in residency you're getting a paycheck, don't go nuts with it. And even when you're out of residency and you're like, whoa, I'm getting paid. Wow. That's when having a financial planner will help you, because I was like, yeah, I can get cable and internet in the house. And having someone help you out with that. Also figuring out, okay, well, what are my goals for the future? Do you want to buy a house? Do you want to travel? When you're looking for that first job, speaking with other physicians about, okay, well, how should I negotiate for my pay? How do I negotiate salary? What do I need to look for in a position? And if you get a job, okay, make sure you have that time to sort of rest before you go into it. When you're applying to jobs right out of residency, you already have the skills that you've done, that getting hospital privileges is easy, and it's best to get those early on, so if you change jobs, you can still have those privileges. Say, oh, I just have privileges at this hospital, let me go to this one. Because if you have a certain amount of time where you've not been in the hospital, it can be harder to get hospital privileges in the future.
So what are hospital privileges?
Yes. Hospital privileges are saying you could call up and say, hi, this is Dr. Tedda, we need to admit this patient to here. Or if, as a pediatrician, I need to go to this hospital to see this newborn because they're going to come to me as an outpatient. I can evaluate them, write the notes and everything. You just can't walk up to any hospital and just start seeing patients saying, well, I'm a doctor, you need to let me in. This is the process that you don't really see as a student because, yeah, they do all that paperwork for you, but it's different as a clinician. You have to get ready for doing a whole lot of paperwork where you're going to be writing your name, your medical, your NPI number, your medical license number, on so many different things, signing all these different papers, signing papers to be working with different health plans. There's going to be a lot of paperwork, but sort of having that idea that, okay, I'm going to be doing a lot of paperwork along the way, and it's going to take time sometimes, that even if you find a job, it's going to take time for all the paperwork to process before you actually start. So keeping that in mind. Also, with any job you look for, asking specifically about, well, am I going to be on call? What is the process for this? And knowing all those things going in. And also, if you're in a position that it's not working out, or if you're not feeling like this is really my niche for the future, being okay with that and saying, okay, if I need to find something else, I need to look at other things. That doing a locum tenens assignment is something that you can do in the interim to help you sort of figure things out. Or I know I've worked with people that were locums as they were waiting for their position to be open. So then they weren't sitting around for 2 months like, I'm not doing anything, I have loans to pay, being able to work on that too.
Okay, and so since you mentioned paperwork, that kind of reminds me of EMR and like the changes with EMR. So how has medicine changed since you started practicing, and where do you see it going in the future?
Yes, EMR, I've transferred from paper charting to EMR in 3 different places that I've worked. And going through that transition, at least I was familiar with it. There were some other people in the office that had never done it before, and it was harder for others than others. I will say there's more of a move for having like these minute clinics, and you go to the Walmart and there's a clinic over here, or there's urgent care. And I'm seeing more of patients going to these other places, or they're trying to use the emergency department as, oh, I had a runny nose and I couldn't come here, so I went to the emergency department, which is not a good allocation of resources. And as we see politically, there's a lot of issues with healthcare costs and how do we keep them low. And I think a big part of it is educating people about, well, this is what deems appropriate for the emergency department, and here's what you need if you just have a runny nose or a rash. This is not something you need to go, because we're seeing rising healthcare costs, and part of it is emergency room visit is about $500 baseline just to take someone's vital signs. And that's a number I can recall from when I had to go to the emergency department after a car crash, and that was years ago, so it's probably changed. But I'm seeing more of increases in healthcare costs, which also makes it harder sometimes to get into offices if so many patients are assigned because they want to use their insurance before it runs out, or if people can't make appointments because you have to have this many patients in your list of patients in order to be able to keep the business head above water, that we're having more people either turning to emergency departments, minute clinics, or their colleagues on social media asking them medical questions. And so the challenge for me as a clinician is coming in as someone either showing me information, well, this source said this, or I went to the ED and they told me this, And I don't know if where they got the information from, or maybe if that person they got the information from, were they really accurate? And then having to deal with that, that I'm not the first person they're coming to for information, I might be the fourth or fifth. And so either I need to uneducate them on the things they've come in with, asking about, or say, okay, that person was correct, but here's what we need to look out for. I think I had one parent with a 2-year-old, and they said, oh yeah, I was told if my child's choking, I should just push the food down so it goes down their throat. And I looked at him and said, and who told you this? And they said, everybody. And I said, please don't do that. Please don't do that to your child. That's not what to do. But this is what they felt was appropriate. Today, during didactics, someone told me, kids don't talk until at least 2 years of age. They don't communicate. And I thought, they must have never been around a child. That's not how things go. I think with medicine, it's sort of understanding that people are going to tell me, well, Dr. Oz said this. And I don't know if that goes with Dr. Oz. Sort of understanding that people may rather look at the talking heads on TV or on their computer than come to their clinician first for medical advice.
On the flip side also, I feel like, well, maybe more of a minority of people with access to technology, they have like maybe sometimes an abundance of resources that are sometimes valid, they look at. And since medicine is changing so much, how would you recommend people stay on top of their field as clinicians?
Excellent. Yeah. I will say that is when being involved in medical education really helps. As a fellow, I worked with students and residents, and so as they were learning things, I was getting updated on things. Different health conditions, the names change a lot. And so even this year, someone mentioned something, and I said, what? That's a new name for it? Man, because they're always changing things. As you mentioned, this is where, for me, the American Academy of Pediatrics keeps updating information and making sure that their membership is aware of, changes with the flu vaccine and how that should be administered, changes with the HPV vaccine and the schedule, or what are we doing now for GBS screening? Are we going to do it for children that are term, or do we do it when they're premature? And these are things that have changed even in the short time between me being in residency and now, that you have to sort of seek out these things. It's not just going to appear to you. You need to look for them by staying in touch with your local group that's affiliated with that area of study that you're in.
Okay, and so last question, what advice would you give medical students and residents to become good doctors?
Don't give up. If medicine is your passion and that's what you want to do, don't let an exam score, a bad encounter, a naysayer stand in the way of that. Because I tell everyone when they want to go to medical school, and I tell them, no, A, it's not easy, and B, when there's a really rough day and you're just sitting here going, is this really for me? You're going to still be the one that has to go through the exam or go through that overnight being on call. You're going to have to be going through it. That if you're going to be going through it, you better be doing it for the right reasons, because if you're not, you're just going to burn out on this stuff really early. If people tell me, well, I want to be really rich and be a doctor, okay, there are many things you could do in the world and be really rich. But if you want to be a doctor, okay, you may not become really rich doing it, but you'll find satisfaction in it if it is what you really want to do. I think that's the first question before anyone even applies to medical school. Make sure that's really where you want to be. Also, when it comes to picking which specialty, when you're in your rotations, getting a feel for it, is this really what you want to do? Is this what you find interesting? There are many times I worked with attendings that they'll tell you, whoa, I really wanted to do surgery, but you know what? My spouse at the time didn't want me to do it, so I did OB-GYN, and now I divorced them, and I'm in an OB-GYN now. And you could tell they were unhappy, but they're like, what am I going to do now? I've been doing this for 30 years. I'm not going to switch. And for me, I thought I wouldn't want to be doing something and be unhappy about it, let alone telling everyone and their cousin about it, that when you make the decision for the area of medicine you're going to pursue, make sure it's your decision too, because that's what you'll be dedicating the majority of your time to. And if you're going to do it, you want to do it because it's your choice. Also, take care of yourself. Make the time to take care of your own health needs. I've known a few people during the path to becoming physicians that either left medical school or left before they even got into medical school or left during residency. I've known people that when I was a second year in medical school, 2 students in our school committed suicide. Mm-hmm. I know that it can be a stressful time, and making sure that you're taking care of yourself first. We're taking care of other people, but we need to take care of ourselves first. Like they say in the airplane, when the oxygen masks come down, put yours on first before you put on others. That if we can't be healthy ourselves, how are we expected to take care of other people? I think that sometimes we get so stressed and we're like, you must study, you must do this, but we need to remember, you need to make sure that you're okay. Mm-hmm. If that means I need to take off from this rotation, or if it means I need to speak with Dr. Yip because, things are going on, I need to come back in a year, or if you need to come, do what you need to do, figure those other parts out, money, whatever, those things will come together, but making sure you're taking care of yourself most of all.
Mm-hmm. Okay, that's some good advice. Okay, so that wraps up this interview. Thank you guys for watching. If you have any questions, leave it down below, and let me know who you guys want me to interview for the next interview. Thank you guys again for watching, and have a great rest of your day.